Okay. Good evening, everybody. I would like to speak for not so fancy subject about shoulder pathology, which is the painful biceps conditions. First of all, I would tell a few things about the biceps tendon. It's a biarticular muscle, although it is considered to be a muscle of the humerus, does not actually touch the humerus. Anchors from radial tuberosity below the elbow and goes up to, with two tendons, the long head of biceps, which goes inside the shoulder articulation, and the short head of biceps, which goes to the coracoid process. It's a main pain, is the main source of pain in the shoulder. Is often associated with rotator cuff tears, although the spectrum of the long head of biceps, which is the main cause of problems in the shoulder, includes primary and secondary tendinitis or probably chronic tendinopathy, slap lesions, instability, and ruptures. Let's stay first for the long head of biceps, which is the main tendon, which actually bring the patients to the doctor for treatment. It's a secondary shoulder stabilizer, limitation of the humeral head migration, has a variable stabilizing role based on elbow position, elbow and shoulder flexion, and the forearm is the main supinator of the forearm, gives the most part of the forearm supination. But it's a common source of discomfort and disability, most often at the superior labrum of the glenoid and the proximal bicipital groove. This happens because of some mechanical causes due to traction, friction, and glenohumeral rotation. It's the anatomy that makes the long head of biceps so painful. Its origin to the supraglenoid labrum and supraglenoid tubercle of the scapula, this is called the biceps anchor, goes down to the anterior and superior the humeral head and enters the bicipital groove and goes down to the radial tuberosity. Most of its fibers, 50% of its fibers are touching the labrum and 50% to the supraglenoid tubercle, which is located 6 millimeters medial to the glenoid surface. The structures of in a sagittal view is something like this, so we can understand why supraspinatus and the long head of biceps is so easy to get injured, because they have the acromion above and the head of humerus below, so it's between two bony surfaces, and they have all the time friction and constant injury. This is an arthroscopic view from the long head of biceps. The main regions, as it goes down the humerus, is the intraarticular one, from its origin to the entrance of the groove, the suprapectoral, from the entrance of the groove to before the insertion of pectoralis major, and the subpectoral one. This has a role for us because we try to find the best place where we should anchor and make the tenodesis of the biceps. It's a very big discussion about where is the best place, for advantages and disadvantages in every region. Its main actions are, it's a superior stabilizer. It actually centers the head into the cavity. It's a limiter of external rotation, lifts the glenoid labrum during abduction, and provides a glenohumeral stability if rotator cuff and labral pathology is present. That's why, because it's a very good stabilizer of the head, nowadays we think about, again, when we have a rotator cuff tear, just to use the biceps and not to cut it, in order to stabilize in order to center the head again into the cavity and try to put stitches to the muscles, to the tendons, before and after, to the posterior side, the infraspinatus, and the anterior side, the supraspinatus, in order to replace the rotator cuff. Its main biomechanical function seems to play a relevant role in force dynamic movements, That's why has a high incidence of pathologies in throwing athletes especially. The most lesions happen during the maximal external rotation and acceleration phase of the throw. That's why it was considered that the best way to rehabilitate should involve exercises for the first 30 degrees of flexion, where the biceps enhance the stabilization of the humeral head. Painful bicep conditions. It's well recognized, as we said before, as the main pain generator in the shoulder. It's often associated with other primary shoulder pathology. The main painful conditions are tendonitis, or let's say better, a chronic tendinopathy. It's not an inflammation. Acute chronic rupture, slap lesions, and traumatic pulley instability. As far as tendonitis or tendinopathy, because it's not a true inflammation, it's an anterior shoulder pain radiating down the region of the biceps. Symptoms may be similar in nature and location to rotator cuff or subacromial impingement. We can see here an arthroscopic view of a torn, injured tendon, the long head of bicep tendon. Many tests, from simple tenderness over the biceps groove to speed test to Jägerson test. Treatment. Usually we want to be non-operative. Non-steroid anti-inflammatories, physiotherapy strengthening, steroid injection is the first line of treatment. We don't want steroid injections to go into the tendon. We want to be around the tendon as far as is possible. Nowadays, with ultrasound guidance, this is more easy than before. When we have to go to operate it, operative arthroscopic tenodesis or tenotomy. Surgical release for tendinopathy is reserved only for refractory cases and concomitant pathology seen during arthroscopy. Post-op rehabilitation for tenodesis, which is the main thing we do when we do an arthroscopy in the shoulder. We make a tenodesis to the biceps, no matter where, intraarticular, subacromially, subpectoral, suprapectoral. We have to avoid active forearm supination with the elbow at 90 degrees of flexion against resistance. Avoid active elbow flexion against resistance. If we make a tenotomy, this will come with arm cramping and may cause a cosmetic deformity, the popular Popeye deformity. Tenodesis may be associated with groove pain because we put stitches, 1 or 2, inside the groove, and this may provoke a more inflammatory reaction inside the groove. Practically, there is no difference in strength between two techniques. Both recover elbow and forearm strength very well post-operatively. If we have a biceps rupture, although the distal biceps tendon, when it's ruptured, we want definitely to anchor it down to the radial tuberosity. The long head of biceps is not really a problem, even if it's acute rupture or a chronic rupture or acute on chronic rupture. This is the Popeye sign. All the muscle belly goes down to the humerus because the long head of biceps tendon is not attached to its place, to its insertion. And actually, if it's not a cosmetic problem, we leave it that way. If it is a cosmetic problem, we try to make or a mini open incision or actually arthroscopically and try to reestablish the ruptured tendon to maybe at the entrance of the groove or if we can subpectoral or suprapectorally. Slap lesion is a very common pathology. Sometimes asymptomatic, usually very symptomatic, is the superior labrum from anterior to posterior, which may or may not involve the biceps attachment, the biceps anchor. It's less than 5%, but it's very common pain generator for the shoulder. The mechanism of injury is usually during repetitive overhead activities. The problem is that SLAP lesion has actually no specific test. Although have been described the Yergason, the crank test, the O'Brien, the speed test, there is nothing that we can say that if it's positive, yes, it's SLAP lesion. So we have to be highly suspicious to search for vague, deep shoulder pain, mechanical symptoms of popping or clicking. We have to ask the patient, weakness, easy fatigue, decrease of athletic performance, evaluate everything, the doctors or the physiotherapist, always compare to the contralateral side. The typical classification from Snyder, it's only for surgical reasons. It's up to us what we are going to do depending on what class the type is. The non-operative treatment is usually physiotherapy and non-steroid anti-inflammatories. We always should address the GERD if present. Rehabilitation should focus on scapular dyskinesia and rotator cuff strengthening for all patients. The arthroscopic debridement, although it depends on the type of the lesion, actually is tenotomy or tenodesis. We don't anymore try to fix the labrum, we just try to make the patient not feeling pain. And this happens by placing the long head of biceps tendon more distally at the entrance of the groove or even distally. The last but not least, the biceps pulley instability is a soft tissue sling. It's the stabilizer of the long head of biceps tendon from the interarticular space into the bicipital groove. It's a direct component of the superior glenohumeral ligament and the subscapularis. Often found in patients, more common in older ones, 7% incidence in arthroscopic shoulder surgeries. The fact is that these are progressive lesions, so it's not easy to rehabilitate them and make asymptomatic patients. This is how it's seen during arthroscopy. Possible pathomechanism for biceps pulley are injury of the tendon, slap tears, and their superior impingement. Are associated with chronic subluxation, dislocation, discomfort of the patient, increased risk for chronic tendonitis, RC tears, especially supraspinatus and subscapularis. What is the treatment of biceps pulley? Biceps tenotomy or tenodesis. This is the main thing we always do during we have to deal with the biceps tendon. Tenodesis is more preferable because there is a maintenance of the length-tension relationship of the bicep muscle. The muscle length can be altered easily by changing the elbow angle, and the maintenance of the elbow flexion and supination strength for maximum elbow function. In general, tenotomy, older patients, women, large patients, non-dominant hand, tenodesis, active patients, young patients, slim, and patients concerned about cosmesis to avoid Popeye deformity. Take-home messages. We want always to talk to the physiotherapist. As I told before, and even for biceps matters, the physiotherapist must know if there has been a tenotomy or a tenodesis, in what region, has to know about all the concomitant pathologies of the shoulder, because it's a very important issue and plays an important role in shoulder arthroscopy. Is the shoulder and elbow flexion, humeral head depresses the humeral head, is the main forearm supinator, and we have to be very careful with it. So, is the main pain generator. The biceps pulley lesion can cause anterior shoulder pain, are more common in older patients, and they are progressive, so operative treatment is always needed. Tenotomy, older inactive patients, tenodesis wherever this is, tenodesis near the distal end or below the groove when major pathology or very sensitive bicipital groove to avoid a further irritation of it. Thank you very much.